When we talk about treating arrhythmias, it's not just about identifying the rhythm, it's about choosing the right tool to restore stability. Management depends on whether the problem is acute or chronic, the underlying cause, and how much the arrhythmia is affecting hemodynamics. Sometimes we're using medications, and other times we're reaching for electrical therapies like pacing, cardioversion, or defibrillation. On top of that, we have implantable devices like pacemakers or ICDs, and in certain cases, surgical interventions. As nurses, our role is central. We're the ones monitoring the patient, recognizing changes, and supporting them through procedures that can be frightening but life-saving. Let's start with cardioversion and defibrillation. Both involve delivering an electrical current to the heart in order to depolarize a critical mass of myocardial cells. When those cells repolarize, the SA node often reclaims its role as the heart's natural pacemaker. The key difference is timing. Cardioversion is synchronized with the QRS comps on the ECG. It waits until ventricular depolarization to deliver the shock. Defibrillation, on the other hand, is unsynchronized and delivered immediately. Both use the same device, a defibrillator, but the voltage required for defibrillation is higher and can cause more myocardial damage. Modern devices are biphasic, which means the current flows in two directions and then back, making the shocks more efficient and requiring less energy than older monophasic models. Placement of the paddles or pads is also important. Standard placement is on the chest, but sometimes anteroposterior placement is used, with one pad on the chest and the other on the back, just left of the spine. Safety is key. We use only approved conductive mediums, never substitutes like ultrasound gel, and we make absolutely sure no one is in contact with the patient or equipment when a shock is delivered. Hands-off pads are preferred in many settings because they reduce the risk of accidental shock and make the process safer. Now, when you're assisting with external cardioversion or defibrillation, there are several steps to keep in mind. Pads or paddles must be placed correctly with conductive medium in place, avoiding patches, linens, or oxygen flow. For women with larger breasts, the left pad should be placed under or lateral to the breast to ensure good contact. When paddles are used, they must be pressed firmly, about 20 to 25 pounds of pressure, to make sure there's no arcing of the current. If you're in cardioversion mode, the defibrillator must be set to synchronize, and the patient must be connected to ECG monitoring so the device can identify the QRS complexes. In defibrillation, the machine is unsynchronized by default. Whoever delivers the charge announces clearly, charging to number of joules, and then calls, clear, 3 times while visually confirming that no one, not even themselves, is touching the patient or the bed. After the shock, CPR is resumed immediately if the patient has no pulse, and rhythm checks happen after 2 minutes, along with medication administration to improve the chances of successful defibrillation. Once the event is over, the nurse checks the patient's skin for burns, restocks the equipment, and makes sure the defibrillator is plugged back in and ready for the next emergency. Let's take a closer look at cardioversion itself. Electrical cardioversion is a timed shock delivered during the QRS complex to terminate tachyarrhythmias. Synchronization with the QRS is critical because if the shock were delivered during repolarization on the T wave, it could actually trigger ventricular fibrillation. The device must sense the QRS complex, and sometimes the lead or electrode placement has to be adjusted to achieve this. Because of that slight delay, the discharge buttons need to be held down until the shock is actually delivered. If the first cardioversion attempt fails, remember that many machines automatically reset to unsynchronized mode, so the synchronizer must be reactivated. When cardioversion is elective, for example with atrial fibrillation lasting longer than 48 hours, anticoagulation for several weeks beforehand may be needed to reduce the risk of thromboembolism. Digoxin is usually withheld for 2 days before the procedure. The patient is kept NPO for at least 4 hours. Pads are typically placed in anteroposterior position, and the patient receives moderate IV sedation, oxygen support, and monitoring throughout. The shock voltage may range anywhere from 50 to 360 joules, depending on the defibrillator and the patient's condition. Success is indicated by return to sinus rhythm, stable blood pressure, and strong peripheral pulses. Afterward, airway management, oxygen monitoring, and vital signs remain nursing priorities until the patient is fully recovered from sedation. Defibrillation, by contrast, is the emergency intervention of choice for ventricular fibrillation and pulseless ventricular tachycardia, the leading causes of sudden cardiac death. It's never used in patients who are conscious or who have a pulse. Energy settings depend on the device. Monophasic defibrillators require 360 joules, while biphasic defibrillators require 150 to 200 joules initially, sometimes increasing with subsequent shocks. The sooner defibrillation is applied, the greater the chance of survival. In fact, if CPR is begun immediately and defibrillation happens within 5 minutes, survival with intact neurological function increases dramatically. This is why automated external defibrillators, or AEDs, placed in public spaces are so crucial. They shorten the time from collapse to shock, saving lives in airports, malls, schools, and stadiums. If the first shock is unsuccessful, epinephrine is given to increase the likelihood of success with the next attempt and to improve blood flow to the brain and heart. If the arrhythmia persists, antiarrhythmic medications like amiodarone, lidocaine, or magnesium may be administered. All the while, CPR continues, alternating with rhythm checks and defibrillation attempts until either a stable rhythm returns or the code is ended. In summary, electrical therapies are a cornerstone of arrhythmia management. Cardioversion resets dangerous rhythms when the patient still has a pulse. Defibrillation is the last line of defense when the heart is quivering without output. Both require precision, teamwork, and safety vigilance. And in every case, the nurse is the bridge between advanced technology and human care, ensuring procedures are carried out safely, supporting patients and families, and restoring rhythm when seconds count.